Hi, everyone. It's Dr. B with Addiction Recovery. Today, we're going to continue with the series that I have been discussing with Dr. G, who's here with us today. And he's our clinical director for our behavioral mental health programming at American Addiction. And we've been exploring some topics, and I do hope you give us some feedback about what kind of thing you want to see. And we decided to it was probably more my pushing, but we decided to go with personality disorders, in particular at this time, cluster B type, and to initiate with the narcissistic personality disorder classification in general, and substance abuse. And I think today we're going to be talking about narcissistic personality disorder and alcoholism and treatment. This is not very scripted. We're, again, looking for a lot of feedback from you guys. But my own interest in this issue is sort of a multi-level and a lot of folds to it. One, I just find a lot of these disorders very interesting, both professionally and in my historical personal life. Two, with narcissism in general, there's a lot of information on YouTube. There's a lot of articles that you find on them, and quite a bit written in the academic publication and output on this issue. And I find it of particular interest and fascination, again, both in general, but and also in terms of treatment. I'll give my little kind of thing on it, and Dr. G, you can kind of clarify it. When I'm going to talk about narcissism here, and if you want to define it and narrow it or broaden it some more, I'll give the listener a little background here. We're going to, narcissistic personality disorder is defined by DSM-5, Diagnostic and Statistical Manual for Diagnosing and Coding psychiatric conditions. And in there, it's called narcissistic personality disorder. But I'm more interested in a much broader sense of the term, because those sort of become academic constructs of the disorder, which theoreticians and researchers and people working with these patients or these clients like Dr. G have a much stronger grip on, where they can sort of define their, I think you guys go by columns of personality. It's called the 5-factor model or something like that. And again, I'm not sure you can enlighten us. But so I mean that broader category. Why this is interesting to me in treatment in particular is that in general, with a lot of the cluster Bs, including borderlines, and maybe, I don't know with the antisocial type, but with borderline, certainly there is a lot of substance abuse here. Two, it's very interesting because the disease state itself, or the mental health state, I don't want to quite call it the disease state, is known to be quite resistant to treatment with a lot of these. And with narcissism, it's interesting to me because if you don't have insight into something being wrong, obviously it's going to be very difficult to treat. And one of the hallmarks of narcissism, if I'm correct, is they don't have insight into the fact that they know something is wrong. Some of them, they have what's called high degree of neuroticism, which is anxiety and depression with, and maybe paranoia and so forth. But they don't understand that their behavior and actions in the world and the things that they say are, I guess, dysfunctional, unhealthy. And so when you bring this into treatment, I would think it even makes it much more difficult. And finally, on my part, I think I have a difficult time initially recognizing these folks. And that might be because of my own deficits and defects, but, I think they appeal to me in a sense and sort of know exactly where to hone in, where I just actually enjoyed the interaction initially until the red flags keep going up. So if you can give us a little background here, and then really if we can get into the issue, which I know it's out there, by the data and the numbers, alcoholism in particular with narcissists, it's there. So can you give us a little background, and then we'll, I can ask you some questions and difficulties I've had.
Absolutely, Dr. B. I think, the way I would go about it is that I would really go to the core problem with narcissism, which, besides multiple different symptoms that really people can look it up, it's almost a common knowledge nowadays. However, the core issue being the self of the person, meaning the self-concept, the self-esteem, the self-valuation. Now, the reason we have a big problem with that, both in non-substance abuse related therapeutic modality, for instance, we're just dealing with, let's say, someone who has depression, anxiety, or interpersonal problems, and or even with substance abuse, is that what we are trying to treat is really antithetical to what they conceptually believe needs to be treated or is happening, which is a healthy self-evaluation. When we are talking with a person who is an alcoholic or drinking or using drugs or whatever they're doing, what are we doing? We are helping them realize that their behavior and behind it, the choices they're making are not very functional. They're kind of destructive. They're self-harming. So,
and they're open to that.
Generally, people are open to that.
Normal
right?
people would be open to that criticism without a complete destruction of the self and thinking this as an attack on their personal integrity, and they need to come back and destroy you.
Exactly, absolutely. And we don't have that healthy level of self-examination because a narcissist just does not allow that, because the authority, and that's can be to some extent conscious, but mostly subconscious, the authority that legitimately is justified to make that decision is not outside of them. It's inside of them. They are the only ones who would allow themselves or anyone in the world make that type of judgment. So that itself is part of the pathology, because they don't allow anyone else to be in that position, that higher level of position where the narcissist can be examined or valued or judged by someone else. So that's why it goes antithetical, because when they go to therapy, what do they have to do? They have to start trusting that someone else should be doing that judgment.
So let me ask you this. Would you even find, let's say, a narcissist alcoholic seeking help? Because in their mind, if I'm understanding you correctly, there's nothing wrong with them. So why would they even end up in any kind of recovery program? And we can talk about this, we can expand this, and we're trying to stick to substance abuse, but they wouldn't even seek help in the first place for anything, mental health. So much for alcoholism. So do we see them in my line of work?
So we do in substance abuse more often than in pure mental health. And the reason for that is secondary benefits, because they're losing relationships, they are alone, they're isolated. Legal issues, especially with substance use, they're much closer to a physical damage, right? A tangible.
It's much more visceral that something's wrong.
Visceral, absolutely. That's why they're seeking, and that's the point. That's the whole problem with the presentation, because they're not coming in ready or willing to admit that their choices or their behaviors, their approach, their in basically like internal mechanism, internal worldview, has anything to do with these problems that they're experiencing. They're always externalizing. So in reality, even that visceral pain is being projected to others, onto the society, perhaps even onto the drugs, right? So the only reason they're there is because they're hurt, they're in pain, they want some remedy, and it's really a fantasy and wishful thinking if you think about it, because what they are seeking does not exist.
Right. And I'm glad you bring that up. and I'm going to try very hard to stick to our topics, alcoholism or substance abuse and a narcissist. But you said something, what they're seeking does not exist. And when I've been able to sort of pick these people out, I've noticed there is radical cognitive dissonance in a odd way. And recently, and I can't recall his name, it was called Mask of Sanity. And there was a section in there about the psychoneurotic, and it's talking about these personality types. And it's very interesting you said that, because there's such a internal lack of harmony between severe anxiety, paranoia, depression, and it can't be observed. And you can't really say, well, this person has hallucinations or delusions or is by clinical definition psychotic, but they are grossly detached from anything real. And so now we're talking about this, substance abuse and alcohol issue. And I just, how are they going to find treatment in all of this? Because they're just not processing anything. Can you give us any?
So I think they can find treatment, and that is to the extent that the program allows harm reduction. I think it's more short-term treatment, if you will, or repeated treatment, right, with some treatment failures in between, but definitely not long-term treatment that relies heavily on, I would say, non-medication-based, behavioral modification, because for long-term behavior modification-based, treatment, healing, they would have to be able to do one of those two things. Number one, either adhere to the 12-step principles, which would require them to turn over their will and their treatment to someone else. Or if they're not even into 12-step, but they want to work on their, let's say, mental health, then they still would have to develop some kind of insight into the predicament that they're kind of co-creating. But they're unwilling to do so because they're not willing to, relinquish the position of omnipotence and, power that they maintain in relationships. So from the get-go, there's going to be almost a secondary agenda, hidden agenda, for them to call the shots, to direct the treatment. And that always goes wrong. When the addict wants to direct their own treatment, that's not going to work well. So again, to answer that question, it's very, very difficult to get them to actually adhere to a long-term treatment. Sooner or later, they're going to clash interpersonally, whether it is with the therapist or some people, like peers on site in the treatment center that they're at, and or with powers to be, whether it's the owner of the treatment center or the program director, clinical director, medical director, you name it. Sooner or later, they have to. It will come to that clash, and then they relapse, they leave ACA, they sabotage, and at times they may even get very aggressive and violent.
I think on my part, I'm certainly going to miss it. Are most of us even qualified to pick this issue up and then address the primary issue that we are sort of seated to address with this secondary dressing on it? Are most of us, I don't think I'm qualified.
Well, most of us are not, you're right, because that is a very good point that you bring up. In my training, clinical training as a psychologist, when we were taught how to deal with a narcissist, there is a sin, so to say, that any one of us can commit. And that is the idea of telling a narcissist
that they're a narcissist.
That they're narcissists.
Yeah, it's very deadly.
It's very deadly. It is so. What is the actual approach that needs to develop? The approach has to be very much almost what we do with teenagers, but from a different, I would say, level of functioning. What do we do when we work with teenagers, that developing mind, right? That is just kind of evolving from concrete thinking into abstract thinking and moral understanding and moral development and identity development. We help them reason better. We help them, strengthen the reasoning faculties with teenagers. If you think about it, therefore, the idea here would be a facilitatory approach. And that is something that works with narcissists. I have worked with clients who have been, suffering from NPD. And so what has worked for me so far is when I, rather than tell them what to do, rather than make them feel that I know better than them and there is something wrong with their psyche, with their self-concept, with their self-valuation, I help them, I facilitate them answering their own questions. So how you go about that is by means of, for instance, with drug use, you start digging deeper and chipping away at the difference between primary versus secondary benefits. They are in for the secondary benefits, right? So you bring that up. You bring that up and say, okay, well, you're here because there is that DUI, because there is some other secondary benefits going on. What if that didn't exist, right? Would you be coming and seeking treatment for the sake of treatment just for yourself if you didn't have to deal with courts or with the dysfunction in the relationship or mom or dad or somebody, partner, forcing you to come to treatment? What is wrong actually with seeking treatment for the sake of treatment? So we will get to the point that they would say that there's nothing wrong with what I'm doing, right?
Yeah, that's fascinating to me. And it's interesting because I just see a lot of barriers at the sort of a micro interaction level. One of the things I've noticed, and again, it's with my limited engagement with this subgroup of patients or clients, is that when they come in and sit down, or when you approach them to talk to them about something, and in your mind, it's a topic at hand. For example, it may be their alcoholism or whatever it is. And after you deal with them long enough, you realize that, and I don't know if you, and I could be wrong, but if you, you might have the same insight. This is an important topic. It has to do with their welfare, with their children's welfare, with their family's welfare. You want to talk about, and you realize that every engagement they have with you has nothing in their mind to do with the meat of the engagement, in this case, alcoholism, but it's to presenting a face that's going to meet the face and how they can, am I saying that rightly?
No, absolutely.
It's a very superficial engagement. And that has to be, after a while, I would think it's tiring for them. They just can't concentrate on, let's get to the meat of the, which really might be one of the reasons, the literature, if you look at the linguistics of how they communicate, they never get into any kind of detail about anything. Now, whether they know it or not. And that's for a lot of reasons. One, they don't want to be held accountable for anything. They don't want to follow through with anything. It's a source of control for them. If you want to say, hey, will you be here tomorrow at 2 p.m.? Yeah, it would take you till 2 p.m. to get a yes or no from them. And I suspect it's for multiple reasons, control, fear of failing, all kinds. But in this case, we want to talk about your alcoholism. And I would assume that, once you are someone experienced and skilled like you are, you must be aware of this, if I'm correct. And do you incorporate that in your therapy and treatment? And how does it play?
Yeah, so I think there is a key word, a key concept that actually would highlight, the problem that I see in terms of treatment with narcissistic personality disorder and addiction. The key word is character defects, as we have heard, and we know that it is being regurgitated in the recovery field and 12 steps. They're always going back to character defects. So think about it. Character defects is a definition, right? And definition of what? Deficiency, something being wrong, some lack of, if you will, value in a person, which is hitting the core issue of narcissism. They don't believe they have character defects. They don't see the world like that. So as you can understand, there is from the get-go, there's like you're putting yourself up for failure if you're introducing that concept of character defects with people who are narcissists.
Which I'm guilty of having done before. And
that's where we have to stop doing.
Yeah,
right?
and sometimes it's because of time. And, try the brevity of, the situation that I'm seeking. Let's get to the point. And boy, it has, I just want to say matter of factly, look, you're not responding to what I'm saying. This is what I'm saying. This is your issue, and fix it. And, I'm being insensitive, I guess, if you want to call it that, to their emotional experience and sense of well-being, but I'm just destroying it. And also by creating an enemy, not a therapeutic alliance in the task at hand.
Absolutely. See, that therapeutic alliance is the key. So the way I would go about it, really, I would stay away from really, chipping away or kind of stirring up this nervous, chord in them, in terms of character defects, in terms of shame, embarrassment, anything that can go into that direction. So what we do is we do rely on building up that therapeutic relationship. How can we build it up? We can only do that by really genuinely establishing an empathic connection with the person who is suffering. Now, we disagree on how and why they are suffering, but the suffering is there. That's a big difference.
Is there suffering for them?
No, there is suffering. Absolutely. There is also a tendency to want to, if you will, deflect from their own inner suffering, right? Because then it would be admitting that there is something wrong. So there's that deflection. And they would also pretend that they are not suffering.
In fact,
right?
Yeah.
But they're suffering. So this is where I go with, right? More or less the nature of human existence. We don't need to rely on a person's self-reported absence of suffering, because it's just self-reported pretentiousness. We know from scientific approach the nature of human existence, what it depends on, and how it works, the mechanics, dynamics of human existence. So it's impossible for a human being not, to be so, if you will, robotic to the extent that they would not suffer at all. Even the narcissists, they suffer too. It's only, I would say the difference is that internal working model, whereas regular folks, people who don't have, narcissism, if you will, they have some healthy, again, self-evaluation and insight and self-examination. They allow for that. They would admit that they're suffering, and they would be comfortable with that fact. The reality that they're suffering. The narcissist is not comfortable with that fact. But does that mean I cannot empathize with that? No, I can empathize with that. I can empathize with the unspoken. That's fine. That's my job.
I'm going to push you here, and I don't mean to put you on the spot, but you said a few things, and I want to sort of push you here, both in so we can get some practical knowledge, but something a little bit maybe philosophical. You said something really important here. You said, we're treating their alcoholism, and we talked about therapeutic alliance between the professional that's trying to treat them and the client, in this case, who has no insight, and we talked about some of the issues they may have. And you used the term, which I'm sure out there, people watching that are kind of a little bit familiar with this, because again, as so many people know about it, you said you want to be empathetic. And that's going to trigger a lot of people. It almost triggered me for some other reasons, because we know, again, these are some of the modern terms that are being used and not necessarily the traditional classic academic terms, but it has spilled over. We know that they target what's called out there empaths. If you're empathetic, That's and that's a target for them to get in, to utilize,
Yes.
to make themselves feel good, whatever they're going to do to you, right? Whether it's there are most of them are highly sexual, somatic narcissists. There's a lot of terms, whether it's the colloquial terms or the academic terms. But when you said to me you want to build an empathetic therapeutic alliance, the first thought I had is, they're going to try and cross the boundaries and use that. And so I'm calling you out on that, and I want, I'd like to get an answer.
Definitely. No, I love it. The fact that you're going that direction actually goes really to what I would call another core issue of, I would say, our humanity in the, 21st century. Basically, the fact that, when we empathize, we also show vulnerability. And also we kind of step into this gray area of responsibility. Whose responsibility is it when we are hurt? And people have this murkiness about it, kind of obscureness about that concept of responsibility. Many people say, well, I could rightfully say that I'm hurt because someone hurts me emotionally, not physically. And that's the obscure area. I would argue that no, there is a clear line between two people. And when it comes to being hurt, people in general have not learned how to take individual responsibility. Now, that is paramount when people empathize. So going back to that example that you gave, a narcissist could take advantage of you. The discussion would be, well, how would you as a therapist, trust that your client as a narcissist would not manipulate you or take advantage of you, right? That's where you're going. So that goes to I would say the bottom of this abyss, if you will, of the idea of manipulation and, again, responsibility in terms of our emotional regulation. Now, if I allow myself to follow the principle that just because I empathize with a narcissist, I am running the risk of being hurt if they disappoint me, right? Then I'm in trouble. Because I'm creating a codependency.
Exactly.
And contingency codependency.
And they prey off that.
However, if I can look at it as a choice, as an experience, I want to empathize with the suffering of a narcissist because I'm actually doing it for my own good, for my own benefit, to improve my competence as a therapist, as a psychologist. Okay? Then that's where it ends. I'm not even concerned what they do with that empathy because I know where the boundary is.
That's the key. You have boundaries and you keep yourself emotionally, physically, and socially safe. Absolutely. In terms of your, whether it's a criminal thing they may do to you or a financial thing they may do to you.
Yes.
So,
and in fact, what one could argue, how do we keep ourselves safe? And doesn't that kind of equate to a little bit of a healthy narcissism? Because
absolutely,
how do we keep ourselves sane and safe? Well, we have to have internal resources in order to do that. So we rely heavily on our own judgment to do that, right?
Absolutely. And for the viewers, just so you know, maybe in the future, if you guys are interested, we can get into it. Dr. G, and he can explain it to us. But, given one intellectual construct of personality within Dr. G's world, personality has different columns and constructs that gets put together, and you look for defects in that, and then you define some of these disorders. One of those columns is, in fact, the fact that we are naturally narcissistic. When that goes above a certain point and a threshold and certain criteria are filled, then they start using that for defining disorders. Would that be a good way to put it?
Absolutely.
So now, Okay, so that gives me a lot. I'm going to keep moving towards there, and please bring me back to something that you think would be relevant. There seems to be quite a bit of, I think in particular with the narcissist versus the borderline, a lot of alcohol abuse. And as someone who deals with addiction in general and substance abuse, I have my own contextual framework that I can make diagnoses and predictions by looking at the person's past life. And, in some senses, a lot of this is coping with the inability to cope on a day-to-day basis for most people. Why is it so hard why is it so prevalent? If you could tell us, is there a prevalence of alcoholism within this community, more than the average baseline population? And what is the reason for it? Is it the same way? Is it no different than how I view it, which is a coping mechanism?
That's right. So I would argue that really we don't have the numbers in terms of prevalence, because in order to have the numbers, we would have to collect the data from people who are coming to treatment. The ones who are just simply choosing not to come to treatment, and we know there are millions of them who, with their sense of narcissism, they don't see any problem in their actions and behaviors until many, many, many years down the road. And maybe when it is too late, then we are missing that data. So how do we really know the true prevalence? So what I would say, however, is that the right approach, at least the way what I follow in terms of helping narcissists who have a problem with drug use or drinking, that I would welcome them to actually take a quite novel approach, which means instead of looking for someone, and many times they do that, outside of themselves, to help them almost with this magical pill, if you will, or magical solution to kind of deliver a one-shot type of an answer and solve all their problems, which usually doesn't happen, and that's why also they don't go to experts. Know that our approach, at least my approach, as far as a clinical, therapeutic perspective is concerned, is that I want to facilitate their own learning, how to get out of that conundrum. Right. So I'm not going to get into with everybody. Exactly. Yeah. You see, that's why many times I don't even care about these personality disorders, because I think
same across the board.
It's just a symptom of a much, much, much greater complexity. We don't need to waste our time with labels. Yeah. There's so much more work to do in establishing the therapeutic relationship, understanding, empathy, and really building insight is a very interesting journey by itself, which can happen with two people or multiple people in the room through that interaction, through that, let's say intellectual challenging, emotional challenging. And what I would add is experiential challenging. Because it's these experiences that can either create more deficiency and defect and problems, or they can create more healing. I am in the business of creating more healing through experience.
So you really brought it home with what you just finished up, which is actually what I think works kindred spirits in this way. I couldn't care less. And this really goes to harm reduction and professionalism and lack of judgment or too much judgment in our industry, what we do. And so whether you're a narcissist, ex-con, whoever you are, whatever your sins are, part of my role here with substance abuse is, and because of the lives they led, is to constant engagement without any judgment. And that seems to build a level of trust. And they get tired of playing the games, and they also open up. And if I hear you correctly, that same thing is applied to the narcissist. It's a different modality of how they see themselves and present themselves, but the same approach, same outcome for them, relative within, same outcomes is going to be different with different classifications of people, but the best outcome will be reached doing the same thing. Is that kind of what I?
Absolutely, and I would add to it that in terms of one major obstacle is the need for control on the side of the treatment provider, the therapist, the psychiatrist, the addiction recovery worker. If we are too invested in terms of needing the patient, the client to improve, then we have a completely different dysfunctional dynamic. Because again, when you think about it, if it is about choices, and in most cases, narcissists, they make their own choices, and many times it is self-destruction.
Very much so.
Okay.
I've
So
seen
if we
that.
cannot accept that, we are stuck in a completely different contingent, codependent relationship. Versus what I do is I accept those decisions and choices. I'm comfortable with that because I truly cherish diversity in the sense of this is a human being who has rights to make certain choices, including death, including destruction, including happiness. It's just a variety of these choices and decisions. I need to respect that. Now, in case this person also makes a choice to remain active in their treatment, in the therapeutic relationship with me, then we have a worthwhile journey to follow and we will get somewhere. As long as I can do that, I don't create codependency and contingency and basically a dysfunctional relationship. In those cases, I hope that, and which I have seen, that connection that you mentioned, just kind of connecting with them, understanding them, and really relating to them as a human being with certain expertise, that will lead to a certain, like I said, facilitation of their own reasoning, of their own faculties, where they actually feel comfortable with the end product because they come to that conclusion, right? Yeah. And we have been a co-traveler.
Yeah, and part of that, I think, and again, now we're sort of swimming in the same waters because it applies to everybody. And you've mentioned a few things. Whatever they want to do, I respect that. And a big part of what we do, and I think this is sort of really kind of what lacks in the industry, is approaching this with a professional attitude and a harm reduction. Ethical attitude means if you want to sleep on the street, you have a right to do that. And I respect you for that. And I'm not going to judge you for that. So that opens up treatment opportunities. Yes. Number two, I think a lot more in your field traditionally than us in medicine, but certainly in substance abuse, because it kind of commingles heavily with your field. These folks will fall in and out of treatment. Mm-hmm. But every engagement and every return where they're not judged opens up a possibility for continued treatment and engagement and improvement.
Absolutely.
The key here is, and I think the key here is, and it takes years to develop this, and maybe it's all the schooling, maybe it's somewhere along the way you develop this. You are able to be empathetic, ethical, and have a sense of universal concern for the patients and clients without being emotionally involved. And it might be because it's not your children that's involved, or it's they're not your loved one. Because I can shut the door here and walk out, knowing something very awful is happening to a patient or client, and really have a lot of empathy and an emotional response without letting it get in the way of my engagement with them, whether it's positive, negative, and exposes myself, or my judgment of them. And I know I have a difficult time in doing that if I'm dealing with someone in my personal life that could potentially harm them, myself, or my loved one.
I think in that part that you're bringing up in terms of the more or less difficulty in that emotional disconnection, if you will, or separation or distancing, when it is a loved one, or if we have so much emotional energy invested in the client's improvement, but we see some kind of counter indications, like let's say they're falling behind, they're relapsing, they're hurting more, they're self-sabotaging more, I think there is even value in that. So rather than just being upset and angry and emotional about it, I think we should take that as an opportunity for learning. That emotional pain that is happening at times of, let's say, setback for a patient, for a client, is not only a reaction. I think it's a window into more or less those dynamics, why certain things are working and why some of the things are not working. Now, certainly it is understandable that, let's say, there's factors outside of their control. For instance, let's say death in the family happening. Okay, we understand that this is an external factor happening to them. They're going through that emotional, pain. It's not necessarily their own individual doing that created that pain. Except of those, situations, what I would say, if they're having a setback, they're struggling with their own recovery, with their success, I would look into that struggle. Even though it is painful, I would actually welcome that. It's like, that setback, that, the proverbial, you take 2 steps forward, 1 step back. That 1 step back is a treasure cove for information about the person, about their, humanism, about their existence in this world. And that's why I'm not really upset about it when it happens. When it happens, I think it is worth pursuing. It's worth understanding, building insight together. So I don't shy away from it. Success, I think generally in our field, not only therapy, but also in general, across the society, we think success has to always be accompanied with joy. And I don't think so. I think success is both joy and pain. So success is more of development, growing, advancing, but not just joyfully developing, growing, advancing. So that's where, I don't have a problem with, and I would recommend that people who want to work with, especially addicts, but, on top of that dual diagnosis with narcissism, that they look at that painful experience as part of success. It's just a different window into the dynamics.
Interesting. So for the viewer, as we're kind of, I want to kind of put this, summarize this, and Dr. G, I want you to kind of give us a kind of capping on all of this. We used narcissism and alcoholism, and we didn't go into really defining what narcissism is. I'm assuming a lot of the folks out there already have some idea of this. Give us feedback if you want more on that. But we didn't get too deep into the actual therapeutic, but I think we got some kernels that I can summarize here. Is the approach to the treatment with some sensitivities to their personality defects is basically the same. They will have a more difficult time in engaging in treatment. And this can be difficult sometimes, but you have to be empathetic to their plight.
Yeah, and I would add that we really need a new paradigm.
Tell me what you mean.
What I mean by that is,
in treatment for them?
In treatment for narcissism, by literally just thinking outside of the box, by not confining ourselves to these labels, to this symptomatology. Really just, and maybe we needed to know that as a basic foundational understanding of what we are dealing with. But now we have to put that aside and really work with the person. That's what we got to do. So in terms of narcissism, alcoholism, right, that's what we started with. I would look at it as very much any other type of a human being that is coming in, with the difference that most likely, and a narcissist with alcoholism doesn't even want to come in, doesn't even want to seek treatment unless they have to. So we wait for that opportunity. When they have to come for treatment, then we want to take that opportunity and establish that new paradigm, which relies on connecting with the person, helping them facilitate their own healing.
So I'm gonna try and extract from that and put it out there. If I don't think you see this too much, but if you're a narcissist and you own that, I guess would be one group of patients or clients. B, I think this is something in here is very important for those of you out there working with this group of clients that can be highly destructive in your lives. But maybe that's too harsh of a set of words, but they can have a very profound draining impact on your work. And C, the family and loved ones, if you're seeking them in treatment. I think what you're saying, Dr. G, really, as long as you as the treating provider, what I'm getting out of it is, number one, you have to have the diagnostic sensibility to pick up that this issue exists. If you do, number one, you can keep yourself protected and safe to some extent in terms of emotional and anything else. But more importantly, if you do, you will understand the journey of the client much better. Mm-hmm. You will be a lot more empathetic to difficulties you may encounter in treating them. And at the root of it, the approach is the same thing you and I do with everyone else. Yes. And you will potentially have I'm getting a good feeling about this, but I think if you approach it this way, you might have a very strong therapeutic impact under alcoholism, but potentially under personality defect, because this might be the first time many of them come into contact with someone, and it's almost like a kid kicking and yelling and trying to get something, and they're not going to get what they want, but they're going to get what's good for them, and they just sort of accept it. They might kind of get tired of it and change their own behavior in approaching you and potentially apply that to other areas of their life. I'm drawing conclusions from what you said, or potential conclusions. Am I too far off?
No, I think I like what you said about the one thing I would go beyond what you said is that I would say, the time for using the narcissistic personality disorder as a diagnostic as well as, let's say, treatment focus has come to an end, I believe.
Yeah, that's very interesting. You're saying ignore it, so, deal with the human being, be very human-centric.
That's it, be human-centric. So I think, the original proposition behind any diagnosis was what? To find a solution, right? To define the pathology and then find a solution. But we know that by very definition of labeling somebody defective, we're creating a problem. We're not creating a solution. So why are we relying on that? So to the narcissist, I would say, don't worry about it. You want to get rid of alcoholism? Come to our office. We will help you get rid of it. Don't get stuck in the label and in this, basically it's imprisonment. That doesn't work anymore. We don't care about it. We are informed about it, but we don't let it become an impediment.
And that itself is your therapeutic arsenal to not even, wow, very fascinating. In fact, it's insightful for me, even potentially dealing with some things outside of my professional life. Okay. So I appreciate that. Okay. Thank you very much. I hope you guys enjoyed that. We are starting this kind of series with Dr. G. I hope he continues to join us. And I think I'd like to stick to the narcissism for a while and then potentially go to other cluster Bs, because I do deal with all of these folks in different places and different times. And we're going to also continue our traditional series of substance abuse and different substances. If you like this video, click above to my left. There's other videos that sort of supplement this series. In addition, if you like what you heard, please click on the link below, subscribe to our channel, and ring the bell. We will see you very soon on our next episode.